Pat Solver. I'm an endocrine-trained internist and emergency physician and the editor-in-chief of a long-standing, multi-authored medical blog called The Doctor Weighs In. You can check it out, thedoctorweighsin.com. And I'm very pleased to moderate today's distinguished group of physicians who are going to discuss the recently released 2017 ACC AHA Hypertension Guidelines. This guideline is the result of almost 3 years' worth of work by a cadre of researchers who meticulously applied the highest standards of research and analysis to be able to come up with new recommendations that are based on the strongest evidence of research that they could find. And following today's discussion, we recommend that if you want to find more information about what's in the guideline, that you visit the Target BP website. And you'll be able to find the guideline in full as well as a whole bunch of other helpful resources. And before we start in with the questions, I really want to congratulate the ACC and the AHA and the 9 other medical organizations who produced what I think is a groundbreaking guideline. I want to thank Jim Madera of the American Medical Association, Nancy Brown of the American Heart Association, and Shirley Bergen of TEDMed for coming together to host this first of its kind collaborative event together. And the reason why it's so important that we're doing this is we know that it can take 18 or 19 years for a guideline like this to actually get implemented. And it's our hope by hosting events like this and other events that will take place across the country that we can shorten that time, and hopefully it'll be not just to 17 years but maybe even to 1 or 2 years when we can get this out into the hands of clinicians and, more importantly, affecting the lives of their patients. So all of these organizations together share a very strong commitment to reducing the incidence of cardiovascular disease in this country. And today's discussion is just another way that they're working together to ensure that the clinical community is informed about the steps that they can take to take care of their patients who are diagnosed with uncontrolled blood pressure. So let me introduce you to our participants. First, Paul Welton. And by the way, everybody's MDs, so I'm not going to say your name in MD. We are all MDs. He was the chair of the guideline writing committee and the lead author of the report, and that was a big job. I don't know what you're going to do with all your free time now. He's a renowned researcher in the areas of prevention and epidemiology of cardiovascular and renal diseases and high blood pressure at Tulane University. Next is Carol Watson, who's a professor of medicine and cardiology at the David Geffen School of Medicine in UCLA, where she's the director of the Women's Cardiovascular Health Center and the co-director of the UCLA program in preventive cardiology. Welcome, Carol. Next to her is Tom Lee, who's the Chief Medical Officer for Press Ganey, where he oversees strategies for measuring and improving the quality of care. And he's also a practicing internist and cardiologist at Brigham and Women's Hospital in Boston. And then, finally, Bob Carey, who was the vice chair of the writing committee, and I assume is now going to have some more free time as well, and also a lead author of this amazing report. He's an endocrinologist and a leader in the field of cardiovascular endocrinology. He's also a professor of medicine and a dean emeritus at the University of Virginia. So, let's get started. Based on this new guideline, there's a huge jump from 32% to 46% in the prevalence of people who will now be diagnosed with hypertension. That's a big deal. Big jump and a big deal. And we know there will be pushback from many doctors. In fact, we're already starting to hear from them about reclassifying so many people who didn't have a serious health condition yesterday, and now we're telling them you have one. So what would you say to those people? What would you say to those doctors who are concerned that they're going to have an increased number of people that they now have to tell them you have hypertension?
Well, I would say we're trying to empower not only the clinicians, some of whom will be doctors, they're not all doctors, but also adults who may have high blood pressure to understand the risk, because this new classification what we're calling stage 1 hypertension. Individuals who are in this range are already at double the risk for a heart attack or a stroke. And we know from trials of lifestyle change and from medication trials that you can improve your health if you get down below. So it is a big jump. The other thing I would say is that we have also introduced a concept of risk estimation, cardiovascular risk estimation. So we're much more careful about who might benefit from a blood pressure medication in addition to lifestyle change. So although the number or prevalence of people with hypertension or high blood pressure will go up quite dramatically, the number who will require a blood pressure medication is only going to go up slightly, about 2%.
So let's dive into this idea that this was all based on not just that you have this number, right, that your doctor's going to write down in your chart, or your husband or wife is going to ask you what your numbers were. It isn't really the number itself, it's the risks. Can you talk to us about, well, first of all, how do you measure this risk, and what does it really mean that I have 130/90, or let's say 140/90, in terms of what my future is going to look like?
So just to reiterate what Paul said, we're really not changing risk. The risk was already there. What we're doing is recognizing that risk and trying to improve the health of Americans by trying to deal with that risk. And so what we are trying to do here is to say that to everyone that we should try to reduce the leading causes of hypertension, which are almost all lifestyle changes. And so we place a tremendous effort, and it's the cornerstone of the guideline, that we introduce lifestyle changes for everyone, whether or not they require medication. But as Paul said, and I want to reemphasize, only a small percentage, about 2%, increase from the previous guideline published 14 years ago in the number who will require medication. So lifestyle is the cornerstone, and we have several components of that lifestyle that I think we should emphasize. The most important to me is weight loss, and then the quality of the diet. So we're recommending a dietary approaches to stop hypertension, or a DASH diet, which is a high vegetable, high fruit, high whole grain, low saturated fat diet. And so one will lose weight on that diet and also have a healthier diet to begin with, both of which will reduce risk. Then
I'm sorry.
Go ahead, no.
Well, if you want to finish with the
Well,
lifestyle?
I'll just mention the others. Salt restriction is very important. Most of us in America are taking a very high intake of salt per day, and we need to reduce it. We need to increase our potassium content of our diet. That's been shown to reduce blood pressure as well as salt restriction. We need to engage in more exercise, and we need to limit alcohol consumption.
So we're going to dive into lifestyle changes and more in a bit, but before we leave this issue of all of these new people that now have a diagnosis that they didn't have before, my question is, and it's really how we're going to frame it to our patients and the public as well as the doctors. Would you say that the way we were approaching it before, by not naming what people had as hypertension, actually did a disservice as opposed to a favor? So now we have all these people who now have this label, and some people have complained about that, but in actual fact, do you think that it will help us to focus on that increased risk they had, even if the word that we put on them was pre-hypertension, as opposed to you have hypertension? Carol, any thoughts?
Yes, I think we learned from prior iterations of the guidelines that clinicians ignored prehypertension to a large extent. And unfortunately, as everyone has said, the risk is there. We didn't create the risk. It's just now it's shining a light on the risk. And I think there are some who will recoil against a label. I hope they don't. I hope they understand, congratulations, we're now going to focus on your risk and get it down. And that's the benefit of these guidelines.
Well, some people have raised an issue that this means a whole bunch of people are going to end up on drugs. And we're going to come back to the lifestyle in a minute. But that's the first thing people are going to think. Hypertension, oh no, now I'm going to have to be on blood pressure medicines. Who benefits from that? I wonder if big pharma had something to do with these guidelines. Is that really, what was the driving factor here? Because we now have millions more people who are going to have this label of hypertension, and some of those, not an insubstantial number, are going to require medicines. These are people who weren't on medicine before. Tom, how would you respond if somebody said that to you? Is this really something a ploy by big pharma to sell more drug?
Sure, I'm sure some people are going to say that and think that, and I have zero relationship with pharma, and I think the report is a tour de force. I think it's a fantastic report. It's very open and honest about the risks that patients are having. I think that there are a lot of patients who should be on treatment who are not on treatment. There are a lot of patients who aren't taking their medications as reliably and as often as they should, who it will be better if they're taking their medications more often. That said, I feel like the big impact of this report for me wasn't, I didn't start thinking about medications. I started thinking about, my patients and their degree of control. I showed some of you, like this, I happen to have in my briefcase, this is my report. My population manager, Katie Alder, just met with me and showed that my level of control for my panel has been creeping up, and I just got it to 75% control. I finally became a D student, and I thought, I'm going to be a failing student again. This number is going to be like 50% as soon as we recalibrate here. But, it's not about me. It's about my patient panel and their risk. And then I'm not going to be better in the office than I already am. I need help working on the diet, the physical activity, and the other lifestyle choices, the smoking cessation, which will make the biggest whack in the risk of all the things out there. So I don't feel like I feel like what the guidelines are going to do is going to highlight the need for my colleagues and I to work together in reducing patients' risk.
And if I could just
Sure.
maybe jump in for a moment and say the science is what drove this guideline. We reviewed close to 1,000 studies. There were 21 members of the panel, none of whom have a commercial relationship with industry. They're not on speakers panels. They don't accept money from industry. Industry is great, but we wanted to have what we call a firewall to protect against that. So it's not an issue. And importantly, there were 2 lay members who were hypertensive patients on the panel who were extraordinarily helpful as we went through it. So science is what drove our decisions. Whether we got it right or wrong, it was definitely science that drove it, and not any interest in whether we sell more drugs or not. In fact, in many people who might have been suggested to take a drug in the past, we're more cautious in this guideline. So although the number with hypertension will go up a lot, the number who will benefit from a drug, according to our best understanding now, is not a very big jump.
Yeah, that's terrific. And I have to say that I watched you on the live stream when the guideline was released, and I was really impressed with how much reading everybody on the panel did to end up with this report. This was really a huge effort and really well done. And I want to just re-emphasize that this is about the science. This isn't about selling more drug or some other kind of agenda. This is really about the science. This is about reducing risk, and this is about getting to better cardiovascular health. But I want to come back to you, Tom, because you were so gracious to share your report card, and I would like to suggest to you that you probably didn't have a D if we graded on the curve.
Okay, I'm all for that. It's not pass-fail. It's not about am I good or not, but
you probably had an A, because what is the current compliance with the recommendations? About 50%, right?
So there's a 50% control rate of blood pressure in the United States today. And so he was at 75%, so wow, he really did well.
Right,
It
and
does
from a
vary a
physician's,
lot.
from a physician's point of view, we're very focused on the grade, right? That's how we got into
Yes.
medical school, and that's how we got our residencies and all that kind of thing. But we tend to forget that you got a 75, and that probably was an A if we graded on the curve, but you have 25% of people who didn't get what they needed. And what do you think? You're practicing, Carol, you're practicing cardiologist, taking care of patients. What about those 20? Why are we not getting anywhere with them?
I have to say, I was trained as a physiologist, lipidologist, but the longer I practice, the more I realize hypertension is driving so much of the diseases I see. So much. So getting these 25% to goal, or to the new goals, will help to reduce premature deaths. There's no question, in disability and morbidity and mortality and a lot of pain and anguish. So I can't congratulate the authors enough on this, because honestly I was very dismayed at the 2014 publication that loosened up blood pressure goals, and I thought, that's insane. Let's get the control down, not go the other direction. So I think getting those 25%, hopefully now they will realize this is serious business, and the data is the data.
What I say as a practicing doctor, I feel like of the big three risk factors, I feel like, okay, smoking cessation is the no-brainer. Cholesterol is actually like the easy one. The drugs don't cause side effects, and my success rate with them is like 90%.
Yeah, because just take a pill, right?
But hypertension is where the hard work, and that's where the real benefit is. And I think that these guidelines sort of make it clear that there is a lot of work, but there is a lot of benefit.
The other thing I really liked about the guidelines is they really talk about a totally holistic, integrated approach. It's not just drugs or just diet or just lifestyle, it's everything. And I hope payers are paying attention and will start to allow us to spend the time to counsel our patients and will compensate us.
What I want to know is who's doing better than me? Who's doing better than 75%? What are they doing?
Well, one of the things we see around the United States is that there's tremendous variability. In some practices, they're doing exceedingly well, as much as 90% control rates, and elsewhere, not so well. And we can see that regionally. In the South, where I live, we don't do so well. Other parts of the country are doing better. And like Tom says, when you get down to it, 90% of our problems are due to three things, like three legs of the stool. It's diet, physical activity, and smoking when it comes to cardiovascular disease. And they're difficult things to tackle, but we have to tackle them. Drugs are useful, but they're not dealing with the underlying problem for most people.
So how do we deal with the underlying problem? And by the way, I want to interject here that I trained in endocrinology as well, but with a focus on diabetes. And everything that we're talking about that'll be good for you for your hypertension will be good for you with for your diabetes as well. I mean, these things are all connected.
And your dyslipidemia and your obesity.
Right, they're all connected. So the question I have is, what we're talking about is lifestyle changes, and you listed some of these lifestyle changes. That's part of it, and we're going to talk about that. The other part is that really what's going on with that 25%, or is there something else going on with that 25%? So let's talk first about lifestyle, and then let's come back and talk about who are those 25% and why aren't we having any success with them? Is it really just that they don't want to follow instructions, or is it that we don't even know who they are?
Well, we're doing progressively better. We always want to be better. We need to be better. When we look at our country as a whole, we have moved up the number who are aware, the number who are being treated, the number who are being controlled. And I think as we have become more aware, team-based approaches in which the patient plays a very important role are important. Electronic systems that provide a lot of feedback, capturing, looking for people, getting the report, wow, I'm shocked. I didn't know that person hadn't been back for 3 visits. So there are a lot of things we've learned. We've incorporated many of these suggestions in the report, and some systems of care are very, very good at detecting all these things and helping the clinician and the team, whether the clinician is a physician or a nurse or a pharmacist or even a healthcare community healthcare worker, helping that person who's the lead and also helping the patient.
So let me just reemphasize what Paul was saying, that team-based care is so important. If I'm a physician sitting in an office, seeing a patient, and having a time deadline for that, I'm not going to have time to do all of the things that are required and recommended in the guideline. So team-based care involving nurses, nurse practitioners, social workers, physician's assistants, pharmacists, and others are going to be extremely important. And I think that we can delegate a lot. For example, we can delegate behavioral dietary counseling in partnership to a dietitian. And so we can partner with those members of the team to deliver balanced, holistic care to these patients, and then we can take advantage of what's in that lifestyle list that I talked about and really make a difference. I think in the past we've kind of overlooked it in a way because frankly we haven't had time as physicians to do all this. So there are great resources in the document, in the online data supplements, and I would urge everyone to look at those data supplements because they give great detail on how to engage in team-based care, who has responsibility for what activity, and how they can all come together around the patient.
At the end of the day, it's all about empowering the patient, supporting the patient, helping them, but it's their body. They have to change the behaviors. Nobody in their right mind would say it's easy. It's not easy, but it can be done, and we've got to work very hard to help and support the patient to try to have them stay healthy, avoid high blood pressure if they can. If they're already there, try to get that blood pressure down. Don't get to the next level up. And,
right. So I agree with all of these. The issue, there's a couple of issues here. One issue is from the practical point of view of the doctors out there who are listening to us, and they're saying, well, that's fine if you practice in a big system. You know, I practiced at Kaiser Permanente, and we were one of the organizations that reached 90%, but you know, there was a whole institution that was around the doctors, and it was all integrated, so it made it really easy. I could write a little prescription, say go get your patient education, whatever. But if you're out there in a different kind of a setting, how are you going to assemble this team and get this team to do the things that they need to do, and by the way, get paid for it?
Right.
So everybody's got to get paid for their work. Right. I mean, these are real world challenges. The lifestyle issues are super important, but they cut across a lot of conditions. And we're not making any progress. So maybe, Carol, you're nodding your head. Maybe you could tell me a little bit about how we can approach this from a practical point of view.
So I am so fortunate to be a part of a great integrated healthcare system that can support all of those things. But I can say even with that support around me, I struggle. I struggle to find time to sit across the patient. And one example was I was counseling one of my patients about her blood pressure about a year ago, and I said, we really need to get this down. She whipped out a magazine and said, look, I'm in the right goal. And I said, that's insane. Let me explain why. There was an extra 20 minutes of discussion that we had. That is not compensated. And so we need some policy changes to allow us to compensate what works, what we know works, and what saves lives. And maybe as a society have some of these hard discussions.
You know, I think one thing that runs through my mind is that, I mean, this report wasn't about doctors and what doctors do. These guys weren't trying to fix the healthcare system. They were trying to talk about, you know, the most common of our chronic diseases. And I think that physicians and other healthcare providers, even ones in pretty organized systems, we're going to have to adapt. And if we don't, someone else is going to fill the space. For consumers, patients who want to do the best for themselves, they will find someone else to help them if we don't figure out how to get organized to help them. So I do think that, what happens between me and my patients during my office visits, I think it's good, I think it's important, but it's not the answer to addressing the goals that are laid out in this report. It is stuff that's going to be happening over time, patients following their weight, patients being more active, patients eating diets that make more sense. And that, I'm doing what I can now in the office. The answers are going to have to come outside the office.
And again, I don't think necessarily this is easy, but at a minimum, there are two members of the team. There's the clinician, whether that's a physician or some other healthcare provider, and there's the patient. There's usually somebody at the front desk. I know they're busy, but they can certainly spot if somebody isn't showing up for their visits. So you can start with two, and you can start thinking, how do I expand that? Is there a buddy at home that can become a member of that team, whether it's a spouse or it's a best friend? Are there other people who can come in to help? Because with chronic disease, we do benefit. We know this from the assembly of a team.
Okay, so I want to drive. If I sound skeptical, it's because as a person who's struggled with some of these issues myself, and yet I'm a physician and I'm knowledgeable and I write about this stuff and I know why I should do it all. It's hard, right? So it's really it's one thing. And I recently had somebody ask me to write about is telling somebody to lose weight and exercise more enough? And what's the answer? Of course, that's not enough. You don't know how to do it. You don't know how to approach it. It's too general. It's too big. And so I think this is really an important thing for us to grapple with, and for all the people who are listening to us who are wondering, how are we going to take it on? Yeah, it is really important. And now I've got a whole bunch of other people that I really do have an obligation. I want to help them, and I'm going to have to help them figure out how to address these lifestyle issues. And you start from the start. You don't become a marathon runner overnight, but you start doing a little exercise, something that's pleasant with friends, walk in the park. If you don't have a park, go to the mall because it's safe. There are ways to start, and we all need to become healthier. We're protecting our own lives. So it's really important, I think, to motivate and to support patients in their goal to be healthy.
It's so terribly important. I completely agree. But we also have to remember that there are some structural barriers to a lot of people.
Yes.
They don't have a mall that's safe to walk, or they can't afford fruits and vegetables to get the DASH diet. I mean, there are real things that are going to require some hard societal discussions about how do we get people better care.
Well, we're sort of getting at what probably the biggest challenge, of our time really, which is, cracking the code on long-term behavior change. And it's not just in hypertension, it's in health in general, it's in education, it's in savings. There's a group that growing out of Penn with Angela Duckworth and Katie Milkman working on trying to crack the code. Financial incentives, they're not going to do it. Financial incentives, will lead to some short-term behavior change, but it goes away very, very quickly. So what is the equivalent of the 401k for behavior change? Something that's complicated on the inside but simple on the outside. That's something that people are really actively thinking about, because it is the biggest challenge for our times, behavior change.
I would just add to that, I fully agree, that this guideline hopefully will promote the kind of research that we need to clarify what that gold standard is for behavioral change in a variety of different ways. I think this guideline will actually serve as a little bit of a can opener for national discussion and for research, and hopefully for implementing better methods.
And as several of you have alluded to already, there are common villains in this. What works for blood pressure works for overweight, works for diabetes, works for lipids. So it's not just blood pressure that is the problem area. We've got several problem areas. And of course, as we've had guidelines come out on diabetes, people who thought they were healthy recognized, in fact, they're at risk. So we have a lot in common with the lipid guidelines and with the diabetes guidelines, that there's a continuous risk from the lowest level of exposure to the highest. And in our country now, I think there is good reason for concern. We've had this lovely decline in rates of cardiovascular disease, both stroke and myocardial infarction, mortality over the years. That has stopped. And in some parts of the country, it's going up again. So there should be alarm bells going off, and it's not going to be fixed by more drug. Drugs are great when they're needed and when they're valuable. At the end of the day, the causes are diet, physical activity, and smoking, and those are the things we have to fix. Not easy, but we have to face it.
Well, I agree with you, Bob, that I think that and you also, Paul, that one of the things that I think this report is going to do is to actually move us away from thinking that drug is the answer and saying, look, there are people here who now have this condition, and the prescription is lifestyle change. Specific. I don't think we've actually talked about alcohol, for example, and I noticed it often doesn't get talked about, but a really important risk factor for hypertension. Maybe this will lead us to start being sure that every one of our patients is screened for their alcohol consumption and understands what the guidelines are, and the specific relationship between hypertension and poor cardiovascular outcomes. So I think that this could actually be very powerful, including powerful in, and I don't want to bring up politics, but it could be powerful in some political ways as well in terms of driving a public health agenda. And I'm wondering what you all think about that.
Well, absolutely. I think it is important, and I think that we can have governmental support for some of the things that are critical in this guideline. And so there are many areas, but one would be control of portion size and implementation of a healthier foodstuffs added into fast foods. And we don't have a government policy on that. We don't have any control over that, and our population is exposed to huge proportions of unhealthy foods that leads to childhood obesity, which then goes on to adulthood obesity and high blood pressure. And I think as a society we need to come to grips with that. I hope our guideline will call attention to some of these problems.
Well, I'm a liberal Democrat from a liberal Democrat state, Massachusetts, but I'm not for the regulation approach. I mean, I think that I can't even regulate myself. I'm not going to regulate other people. I think that I actually do believe in competition. I believe in transparency. I believe that my 75% should be out there, and so I'd like to know who's at 90%, so I might learn from them. And I actually think there is responsibility on the provider side, if we're really about the health of our patients, to try to do better. I mean, I do think that engaging patients in this is a very important message, but we got to try to do better on the provider side. And I'm for transparency on this and not on like process things, like have you put patients on beta blockers or something like that. Like for myocardial infarction, that was very helpful. But I think we're at the stage where we have to measure outcomes and to put it up there, and we know we're not going to be perfect, but it should spur competition and learning and the creation of systems. And if someone says, I can't do it in my current practice model, they should think about how their model should change.
Yeah, it starts with good blood pressure measurement. We as physicians haven't been very good. If you go to a laboratory and you get a cholesterol done or a creatinine done, if they don't meet specific quality control requirements, they'd be closed down. If you fly in a plane, pilots are required to follow very detailed quality control procedures before they take off. We do blood pressures in the office, and the secret, which is not so secret, is we don't do them very well. We can do better, and in fact that's where the patient can be a really valuable part of the team, because one, they can be trained to do very good quality blood pressure measurements, and two, they can provide us with a lot of information for what's happening outside the office. And we know that office measurements, while helpful, really give us a small window on what's happening throughout the day. So I think it would start with making sure we got the diagnosis right before we label somebody, before we put them on any treatments, including drug treatments, and confirming office diagnosis with out-of-office measurements. And there, I think the patient is a key part of the team.
And you have a wonderful section in the guideline on how clinicians should take blood pressure and how patients should take blood
Yes.
pressure. So really, really nice addition.
We don't test it in any of our exams, although it's what clinicians do all the time. You would think that it would be a natural that that's something you might want to know if they're doing well or not, but we ask a lot of other questions, but that's not one, and maybe over time we will be able to adapt to
Right, or we'll
ensuring
have
they're-
people whose specialty it
Or
is to
we-
take blood pressures properly, take the blood pressures instead of having the doctors take them.
They don't have to be a doctor. We're really busy. We have a lot going on. We can get others to do blood pressures, and we know they can do them very, very well.
So I want to switch gears here a little bit because I have a question that I want to ask that is about risks associated with one of the recommendations in the new guideline, which is in stark contrast with JNC 8, which recommended higher blood pressures for people over the age of 60. And there is concern on the part of some clinicians that going lower in all patients is going to increase the risk of adverse events like falls in the elderly that could lead to hip fractures, and we know the consequences of that, or risk of injuries to the kidneys. How do you respond to this?
Well, I would respond very quickly and say when JNC 8 was written, we didn't have a lot of information that we have now. So there have been some big trials, and and truth be told, I chair one of them, the systolic blood pressure intervention trial, in which about over 9,000 individuals participated. About a third of them were over the age of 75 before they started. They derived tremendous benefit from more intensive reduction in blood pressure, and in that group of older adults, those who were most frail derived very, very great benefit. Those who had the slowest gait speed, and we know these are two markers of risk, they had tremendous benefit. And one thing we did not see in SPRINT was serious problems with hypertension, symptomatic hypertension, or falls or fractures. Now, of course, by that, I'm not saying we should be cavalier in the way we treat anybody, including older adults. We have to be careful if we undertake intensive blood pressure reduction. We have to monitor very carefully. But we have several studies now that tell us the one thing we don't see in the trials is a lot of adverse risks. We see a little change in kidney function. It seems to go away when you reduce the drug therapy, if you need that to happen. We have not seen in any of these trials a big problem with falls and fractures, and it can occur. And these trials do not include sick older people like the people who are in nursing homes or in the hospital, so we have to be cautious.
So I agree completely with what you say, but I also agree that every drug has a potential for side effects, adverse events. So it's really important that each clinician look at the patient across from them and tailor therapy to who that patient is. So if they're every time they stand up they get lightheaded and woozy,
Yes,
then
well,
we're not doing the right thing for them.
Yeah. And of course, I just say for the seniors, getting into that category myself now, what we want to do is be healthy. You want to keep older adults out of the hospital, out of nursing homes. They want to celebrate the grandson or the granddaughter graduating or getting married. There are only a few things that we can do that are very effective and well proven to reduce the risk of cardiovascular events and reduce the risk of death. And lowering blood pressure is the best example of what we can do.
Yep.
So gold standard of what we want to focus on, and the people who you were probably most afraid of, you need to be a little less afraid of, but still remember to personalize this based on the individual who's in front of you.
We should
Tom, why don't you give us
Titrating the blood pressure up, blood pressure medication up slowly if they need medication, rather than making rapid jumps is a good idea.
I think Carol said it beautifully. There is risk. There's always risk. Whenever you see benefit from any intervention, there's going to be some risk. We can't be fixated on fear by the few people who have a problem, and there will be a few people who have a problem. We have to think about the overall benefit, and that has been very dramatic in all of the trials.
And we can't forget the risk of not treating. We always think about drug risk of treating. The risk of not treating is I'm going to give you exposure to 30% higher risk of cardiovascular death or MI or stroke, and that's not acceptable.
Both taking care of patients and also doing a lot of measurement for my, in my day job, I would say, first we have and I do have patients who I push blood pressure control on and who have fainted, and I backed, and I was clearly, my blood pressure medication related. But I would say we have a culture in medicine. We have a great culture in so many ways, and I would never do anything else. But we do have a culture where we get paralyzed by exceptions. And we focus on what happened to this one person, and then we get paralyzed. It's important that people recognize that there are no perfect quality measures. There is no quality measure that says the right thing to do for every patient. If it was, it'd be a very uninteresting quality measure. We'd already be doing it for everyone. These quality measures nudge us in a direction where that makes care better overall. We have to have common sense. We have to tailor things. But we need that nudge, because it's so clear from the science, from the trials led by these guys, that we can do better. But we need this nudge, and these guidelines give a good nudge.
And of course we should recognize that these are by definition guidelines. They don't say every patient must be given this recipe. It's just like Carol and Tom said. They're guidelines. At the end of the day, it's the patient working with the clinician to make sensible decisions. If you embark on therapy, doing it carefully, monitoring it carefully, and if there needs to be drawback because of side effects or complication, maybe a laboratory change, you have to do that.
Okay, so great conversation, but we have some questions from the audience. So,
are they tough?
Do they involve math?
I'm going to give you all the easy ones. So the first one is something we haven't really talked about, which is how can we provide people of different cultures advice on changing their culturally specific foods and eating habits, and I'm going to add exercise and every other kind of lifestyle issue that we've talked about, so that they can improve their blood pressure.
If you don't mind me starting, I know the American Heart Association has some very nice culturally sensitive recommendations about diet and things like that. So for Hispanic Americans, for African Americans, things like that. And so that's key. If I tell you to go eat a food that you've never in your life tried or you've hated since childhood, that's never going to happen. But if I explain to you how we can make your favorite food healthier, then that's when we can start to have a conversation.
Healthy mac and cheese?
There is such a thing.
Anyone else want to add anything?
I completely concur with Carol. We have to be able to adapt to the person in front of us and be sensitive to their culture, to their background, to their ability to understand what we're saying and adapt to that.
And I would add to that sensitivity to financial issues, which may limit the patient's ability to get good food and to purchase drugs and a whole variety of things that affect their health care.
This sort of takes us into the whole area that is becoming like the concept of the year in many ways, social needs in healthcare. Everyone knows it's important, but now organizations are actually starting to grapple with it. So understanding cultural issues, understanding social needs, they go together. Like at Geisinger, where I'm on the board, they've actually started a program where they're giving fresh food to a subset of diabetics that meet several criteria who otherwise are in food deserts, where they can't get healthy food, and the diets are culturally sensitive, and they have found that a whole bunch of these people stop being diabetics. And they actually, and their healthcare costs, I know because I chair Geisinger Health Plan. We're looking at the numbers. Their healthcare costs go down from like $14K to $4K. So I think that what provider organizations do, will broaden in response not just to these guidelines, but for the overall challenge of taking better care of our patients.
So we haven't really talked about drug treatment much, and that's why I think this question, and actually several of them kind of get at this same issue, is are there different treatment targets for people with different stages of hypertension? Are there different recommendations, not just for goal, but also for the actual way that you either initiate drug treatment or advance the drug treatment?
Well, I'll start on that. So we, in the guideline, have been big advocates and recommend consideration for beginning for stage 2 hypertension greater than 140/90 with 2 drugs of different classes. And for improvement of adherence, one might consider that those would be in a combination. So that's what we recommend for them. And then for patients that can require one drug, we have a list of first-line drugs, and the evidence behind them is covered in the guideline. And we have special recommendations for African Americans. So among those first-line drugs, we recommend thiazide-type diuretics or calcium channel blockers or both to begin with in African Americans, because in clinical trials, those have been shown to be more protective.
So the starting point for somebody who isn't already on a medication is to determine, do they have another problem that requires a specific drug? We would say, we call it compelling indication. If they have had a heart attack recently in the last year or two, if they have heart failure, if they've got kidney disease, there may be a reason to select a particular agent that also lowers blood pressure. So that's the starting point. And when you're dealing with older adults, it's very common to have another problem going on. And there you want to make sure that if you're picking a blood pressure medication, that it's going to work for the other indication as well as lowering blood pressure. If there are no such indications, then we say the real challenge is to lower blood pressure. There are lots of good drugs out there. We recommend drugs from 4 different classes. We have our favorites. We mentioned them, as Bob said, the long-acting diuretics. Chlorthalidone is one. It's proved to be very good in clinical trials, and it probably beats everything else. The calcium channel blockers are also very, very good. They're nice because they are so-called metabolically neutral. So if somebody isn't going to get their labs done very often, they're a pretty safe choice. They're not as good for preventing heart failure as the diuretic. But those 2 work very well. So-called ACE inhibitors work very well, or somebody who can't tolerate an ACE inhibitor, a so-called angiotensin receptor blocker, ARB, works very, very well. And then, as Bob said, for different groups, we know that particular drugs work particularly well. And African Americans is a good example where there are classes of drugs like the renin inhibitors that are not so good, although most people are going to require more than one drug.
You asked about the target. Our target, once drug therapy is started, is the same. It's 130/80 or less than 130/80. So once drug treatment is started, we want to lower the blood pressure to less than 130/80, and that's pretty universal, even if there is a compelling condition, a comorbidity. There are only a couple, maybe one big example when you wouldn't want to do that, and that's in an acute intracranial hemorrhage within the first 6 hours.
And for older adults, their problem is almost always a high systolic, the top number, and their diastolic is usually quite low, so there we just focus on systolic. But again, it's less than 130.
Less than 130.
Average is
What I would say is that, like, I feel like I learned less about drug choices and stuff, or at least I won't admit what I learned about drug choice. But then like the recommendation, if memory serves me correctly, like you said, once you start a medication on someone, bring them back in a month, and I think that's explicitly in there. And I've got to say that like what I've often done, bring people back in like 2 months, 3 months, that's probably not good care, because I think these people are lost to follow up, and keep, regardless of what drug you start, I think like getting them in care, so you're monitoring, is probably, that was probably a more valuable lesson for me from the guidelines than, you know, some of the specifics you brought up.
Particular choice of drug.
In part, don't you think, because it sends a message to the patient that this isn't just, oh, that blood pressure thing, this is actually a serious condition with serious consequences.
Yeah. And the 1 month thing is there, and that's a specific, you know, recommendation.
That's a class 1 recommendation with a high level of evidence too. So
Yeah, and I don't think
we
everyone's
think it's
doing that.
important, right? I agree.
So I have a question from the audience that I think kind of is a segue from what we were just talking about, which is, okay, so we implement these new guidelines. How long until we see less incidence in hypertension sequelae? How long until we see longer life expectancy? I mean, we roll these out, and let's assume that all of these efforts that we're doing shortens the implementation time. When can we start reaping some benefit?
I think we'll see it. Prevention is very hard to track.
Very hard.
When you have an event, you know it. When you have avoided one, unless you're really looking at the population level, you won't see it. We will see the effects, and I think they're going, you know, the goal obviously in this guideline is to help people to understand their risk better, to understand when they need the treatment, and to get down to lower levels. There's no question that that is going to prove beneficial.
And I do think some benefits you'll see really early. Heart failure reduction. You will see that. And you'll probably see that in a tangible way in your individual patients. If they're very hypertensive and short of breath, you bring that blood pressure down, they're going to feel better right away. Heart failure incidence will go down.
I actually did some research on this, you know, in the past, and it varies with the patient population you're talking about. And that's why this risk assessment stuff is so important, because the higher risk you are, the sooner you see the benefit. But like if you look at Medicare patients, particularly Medicare patients who are higher risk, you know, you start to see, you know, improvements in health, you know, decreased bad stuff happening in like a 2-3 year time frame. For commercial patients, it's a much longer time before you see a return on investment, but it is the right thing to do. You actually see, you know, financial returns on investment in Medicare patients. So people have actually looked at this, you know, insurance companies know about this stuff.
And with lifestyle interventions, they vary a little bit. If you are drinking heavily and you reduce your alcohol intake, it'll have a very rapid effect on blood pressure. If you reduce your weight, reduce your sodium intake, you're going to see it in weeks rather than months. You'll certainly see it within a month. If you're really effective, if you drop your weight 5 or 10 pounds, you'd be a very unusual person not to see that reduction in blood pressure quite quickly.
So the answer to the question is that there are measurable things that we can see right away.
Yes.
But that measuring something that doesn't happen is difficult.
Yeah,
So
it's
actually
difficult.
determining,
Yeah.
you know, when you have an overall decrease in incidence could take a while. Probably longer. Probably the incidence goes down before we can even measure it.
And that's one of the hard things about prevention. Everybody raise your hand. Was the last time someone came to you and said, "Thank you for that stroke I didn't have"?
Right.
It doesn't happen. But I can tell you, you have prevented a lot of strokes.
But I think of myself as a consumer as much as I do a clinician, and I want to do everything possible to stay healthy. So I'm very happy if I can see those intermediate markers go down. If I require less medication, I have high blood pressure, I'm controlled on a very low dose of a drug, I exercise a lot, I try to be careful about my diet, try to be moderate in my consumption of wine, which I love. And
As long as he's talking personal experience, I had hypertension 3 years ago, and I made a commitment to lose 15 pounds, which I did, and I
Congratulations.
kept it off. My blood pressure came down immediately to down in the 110 systolic area, and has stayed there.
So this stuff works.
It does work.
It's not easy, but it does work.
I have another question that's a little different from all the questions that we had before, and it's back to this whole thing, the risk of what number we're going to lower to, and that is, does the guideline address hypotension in pregnancy? Did
Yes,
you
it
address it,
does.
and if you did, what was the
So
recommendation?
there are two key recommendations for either women who are planning to become pregnant or pregnant women. And the first one is to discontinue immediately renin-angiotensin system blockers of any kind, ACE inhibitors, angiotensin receptor blockers, and renin inhibitors must be discontinued because they're all fetotoxic. And then to control the blood pressure, there are 3 drugs that are recommended. And these are labetalol, nifedipine, and methyldopa. And so one of those or a combination of those should be substituted. So those are our major recommendations. We didn't go into a lot of detail, but we thought those were very important for pregnant women.
And how about the target? This question was actually worrying about hypotension in pregnancy.
We made some general statements, but didn't make a specific recommendation.
And we did refer, for people who want a lot more information, there are detailed guidelines on this in some other areas. There's no point in us repeating them. We did provide the referral to those sources.
Yes, so
Okay.
you can look in the guideline and get the reference for the referral.
Again, a good place to go is to Target BP, where you can find all the
Yes.
documents and supporting materials, which is terrific. So another kind of specific question, and we have just a short period of time, and I have a closing question that I have for you. So I'll make this the last audience question, which is, what about resources for young adults with high blood pressure? And I know this was not a pediatric guideline, but I want to just add in, what about resources for people who are treating hypertension in children?
So the Pediatric Society just came out with its guideline for children and adolescents, and we actually coordinated our efforts as we were writing the guideline. So we would, and we have referrals in the document back to the pediatric guideline.
We had a pediatrician on our guideline committee who also sat on the pediatric guideline committee. I would say it's very important because high blood pressure is a chronic problem. It starts early in life, and then it will tend to get a little more problematic later in life. So tackling it early is very, very important.
But overall, for young adults, the recommendations are the same as for older adults?
Yes,
Yes,
in terms of
yes.
blood pressure, they are the same.
Okay.
For people in their 20s and 30s, yes.
So I thought it would really be fun to close by asking each of you, and we'll have to make it a little short, with respect to these guidelines and all this work that was done, what is your biggest fear, right, about what will happen after now that these guidelines are released, and what is your fondest hope? And
Okay.
we'll start at this end and
So
come
I'll
this way.
start. I think my greatest fear is that the guidelines won't be implemented. And if they're not implemented, then our health is not going to improve.
But your hope?
My hope is that the guidelines will be implemented as soon as possible.
My biggest fear is that they'll sit on the shelf, or the virtual shelf, and won't have impact also. And my biggest hope is to go from 75% go from being a D student to a C student, and then see what's beyond that.
My biggest fear is that consumers or patients won't get sort of guideline whiplash. Well, it was here a couple of years ago. Now it's here. What is going on? I hope, and that'll paralyze them into inaction. I hope that doesn't happen. That's my greatest fear. My greatest hope, though, is that we'll finally start to crack this control rate that's been hovering around unacceptably high levels for so long, ever since I've been a doctor. We'll finally get it down and get patients doing better.
Fantastic.
My biggest fear is very similar to the others, that this will sit somewhere on the shelf, that we won't implement what's in that guideline. And the hope, of course, is that the guideline will be implemented, that it will empower clinicians, and particularly it'll empower patients, and that patients will be healthier, and they'll have a healthier and happier life. And you know, that's the core mission of all of the 11 professional societies that have supported this guideline, and it's my greatest aspiration.
Fantastic. So I'm just going to add my greatest hope, and that is that all of you out there who are listening, that you learn something from today's discussion, but also that you start to talk about it with your colleagues, talk about it with your patients, go to Target BP and get a hold of this information. I know people have said, oh geez, this guideline is 453 pages long, but that's actually not really true. That's with a whole bunch of supplements and references and all that kind of stuff. It's actually very well written. Congratulations, you guys. It's very well written, very clear, and it's in sections, so you can access it really easily. So I want to close by thanking the AMA and the AHA and TEDMed for making this conversation possible. And I want to thank our participants for all the work that you've done and your engagement in today's discussion. Thank you very much.
Thank you very much.
Thank you.